Hello, everyone, and welcome to the Santa Barbara Neuroscience Institute's Meet the Doctor, featuring Dr. Michael Gibbs, a board-certified neurologist and the medical director of the Cottage Epilepsy Center. I'm your host, Christina Cortez, Public Relations Manager here at Cottage Health, and I'm so glad you could join us today. Before we get started, I'd like to review a couple of housekeeping items to help make sure you get the most out of this webinar. At the end of this presentation, we'll have a brief question and answer session. So if you have any questions, feel free to submit them using the Q&A button at the bottom of your screen. Also, this presentation is being recorded, and within the next week, you'll receive an email with a link to view the presentation and the PowerPoint slides. And so now it's my pleasure to introduce Dr. Michael Gibbs. Dr. Gibbs earned his medical degree from Northwestern Feinberg School of Medicine and went to complete fellowships in neurology and neurophysiology at UCLA Medical Center. He is board certified in both specialties. Dr. Gibbs joined the medical staff at Santa Barbara Cottage Hospital in 2017 and is a neurologist in private practice here in Santa Barbara. In 2019, he became the medical director of the Cottage Epilepsy Center. Dr. Gibbs' favorite aspect of medicine is teaching patients about their illness and empowering them to become active participants in their recovery. He is firmly devoted to patient-centered care and the idea that each patient is an individual with a unique way of navigating the medical system and coping with illness. Dr. Gibbs is married and has two young daughters. He's a former collegiate triathlete and now engages in cycling for fitness. In addition to his active lifestyle, he also has a soft spot for mid-century furniture design. So with that, please join me in welcoming Dr. Gibbs.
Thank you very much. I'm going to share my screen. Okay, everybody should be able to see my presentation. I am excited and honored to be here with you all today to discuss epilepsy. I'd imagine that some of you tuning in this afternoon are patients of mine. Thank you for being here and supporting me. There are probably also people who either have family or friends who suffer from epilepsy. Other people may be caregivers or hospital staff, or just people in the community who are interested in this important health topic. So whoever you are, welcome. And congratulations for taking this step to improve your knowledge and education on this important healthcare topic. I firmly believe that in our current healthcare landscape, it is extremely important to be an advocate for yourself or someone you love. And in that vein, knowledge is power. So we're going to cover these topics today in the next hopefully 40 minutes. We're going to talk about what epilepsy is and what the causes of epilepsy are. We're going to discuss what types of epilepsies there are and why do we even bother? Why does your epileptologist spend time probing and studying the unique features of their patient's epilepsy? I'm also going to talk about how we treat epilepsy, and that's largely a topic about medications. But sometimes seizures don't respond to medications, and we have other options. So we'll briefly touch on that topic as well. So firstly, we'll start with a few definitions. Seizure and epilepsy, and these are sometimes used interchangeably, but they're actually different terms. So a seizure is a transient episode of abnormal electrical activity in the brain that causes someone to feel a symptom or involuntarily display or have a behavior such as stiffen or shake. So the key words here are it's transient and it's the result of abnormal excessive electrical activity. Sometimes I describe this as like an electrical storm in the brain. Now, epilepsy is a broader term, and it describes a condition or a disease. And in order to have epilepsy, um, someone has had at least one epileptic seizure in the past and an enduring predisposition to have further seizures. So that may be evidence from either an MRI or an EEG that they are likely to have more seizures. But the vast majority of people have had more than one spontaneous seizure. And that's how they reach the definition of having epilepsy. And epilepsy, of course, includes some of the consequences of the condition itself. So the biological, the psychological, and the social negative consequences of having epilepsy. So in summary, a seizure is an event, and an epilepsy is a disease of recurring seizures. So I have a couple of videos that I want to show today, and it's not that I want to sensationalize seizures. The two seizures that I chose were published on YouTube by two young gentlemen who are tracking their experience with epilepsy and their interactions with healthcare staff and their treatments on YouTube. And in general, I think I applaud their efforts because they're raising awareness for the disease and helping to reduce stigma and promote a community of patients and people with this disease who can talk and share information. And so what I want you to, the reason I'm showing you this seizure this young gentleman captured on his own video is because it sort of puts in very stark relief why seizures are unfavorable, why they're so disruptive. And you'll see that in this video.
I'm not so worried about it. And what do you say then? Um, they're not the nicest things to watch, but please press the like buttons, leave comments if you want to, and subscribe to my channel.
So you observed him. I think he was on a video chat with somebody and suddenly had an abrupt loss of speech and stiffening. His head turned one way. He ultimately collapsed, and I believe this is the video stops before the end of his seizure, but he probably collapsed to the floor and has a generalized convulsion. So this is a pretty typical seizure. Not all seizures certainly look like this. Some are much milder. Some are more brief in other people, and sometimes they're actually quite a bit more aggressive than this. So this is a very typical looking seizure. So let's talk about some some facts about epilepsy. So it's the fourth most burdensome neurological disorder. Stroke and Alzheimer's disease are two of the most burdensome in terms of their effects on people's health. But epilepsy is very high in the pecking order. About 3 million Americans live with epilepsy. There are roughly 20,000 new cases of seizures and epilepsy that occur every year in the US. 1 in 26 people will have a seizure at one point in their life. So a minority of those will go on to develop epilepsy, but 1 in 26 will have at least one seizure in their lifetime. 50% of people with epilepsy develop seizures by age 25. So there is a predominance of people developing epilepsy in their youth, but that leaves the other half who are well into adulthood. So this is very much a disease of pediatric or young people and adults. And so now there are as many people with epilepsy who are 60 or older as children age 10 or younger. So sometimes we call this a bimodal distribution. There are the cases of epilepsy are concentrated into the very young and the older. So let's talk a little bit about what causes epilepsy, because this is one of the more common questions that patients have. Why do I have epilepsy? And I think it's helpful to look at how our understanding of this has changed over time. On the left pie chart, this is our understanding as of 1975. And you can see that pieces of the pie are attributed to head trauma or brain injury, stroke or brain bleed, tumor, brain infection, a congenital cause, which is a abnormality of the brain at birth, lack of oxygen during birth, and kind of a potpourri of other causes. And the vast majority, so greater than 75% of the patients in 1975 were deemed to have idiopathic epilepsy. And that is a doctor jargony term that basically means we don't know why. Now, fast forward to present day, and this is our current understanding. So again, we have all of the similar factors that I just mentioned. And here we've tagged on a couple of other explanations that are obvious for people's development of epilepsy. One of them is autoimmune. We know that the immune system is able to attack the brain and produce seizures, and that wasn't obvious before. And with the advent of MRI technology, we now are able to detect small lesions in the brain that we now know are the cause of people's epilepsy that we weren't able to detect with older technologies like a CT scan. So that still leaves us with, perhaps 70%, a little under 70% of the people that we still don't have a specific proximate cause other than an understanding that in the vast majority of these cases, it is underlying genetics that explains people's predisposition to develop epilepsy. So a minority of those are a single gene that we could test for. Most of them have complex inheritance. So it may be half a dozen genes or more that render someone likely to develop epilepsy. And then, of course, there are modifiers and susceptibility alleles, things outside even the genetic code, but that are housed within the DNA that predispose people to epilepsy. So we classify seizures, and this is to help us, as I'll describe in future slides. But let's talk about the two main classifications of seizures. So we have focal seizures and generalized seizures. Focal seizures, as depicted in this cartoon here, they start in one area and they spread. And they can spread a little or they can spread a lot. If they spread only to nearby areas, and perhaps provide a sensation or a feeling, but they don't involve networks that link multiple lobes together, then generally patients remain aware. So they can respond, they'll remember what happens during the seizure. But if it starts to involve, certainly more than one lobe, like a temporal lobe and the frontal lobe, or larger networks than that, then we get impaired awareness. Now, the old terminologies were simple for aware and complex partial for impaired awareness. But these are our new terms, aware and impaired awareness. And then the seizure can end there spontaneously, and the person may recover, or it can spread to both sides of the brain and result in a generalized seizure. And 99% of the time, that generalized seizure looks like a tonic-clonic seizure, or grand mal is the old terminology. Now, so that's focal seizures. Now, the other type of seizure is generalized seizures. Now, these seizures, they involve large networks of both sides of the brain at the onset. So much of the time, the person experiencing a generalized seizure does not get a warning. Maybe myoclonic seizures, if you have a few jerks, that's your warning that you're having a myoclonic seizure. But these other types, tonic, clonic, absence, and tonic or atonic, usually there isn't a warning that you're going to have a seizure. And these result in various types of seizures. So an absence seizure might just be a staring spell, inattentiveness, rapid eye blinking. A tonic or an atonic seizure usually causes somebody to fall to the ground or have a drop attack. And then myoclonic seizures cause high velocity muscle jerks, and that can progress into a tonic-clonic seizure. And to expand on the focal versus generalized features, focal seizures, because they start in one area of the brain and they tickle that area of the brain, can cause a sensation. And that sensation may be a bodily sensation, or it may be just an emotion, or a visceral feeling. So common things are deja vu, fear or panic, epigastric rising sensation, feeling like your stomach is rising in your abdomen, an out-of-body experience or body tingling. And then focal seizures may produce symptoms or signs, things that we observe that only affects one part of the body. So if the muscles on one side of the body tighten, you might get the head turning in one direction or the arm raising on one side of the body. If it tickles the area of the brain involved in some of automated behavior, like chewing or swallowing, you might observe somebody repetitively chewing or swallowing over and over again. So that can clue you in that these are focal seizures. Generalized seizures generally don't have these more interesting features. They are more what I call bland. So staring, blinking, brief body jerks, symmetric stiffening of the body, not stiffening on one side or the other, or suddenly becoming limp, or suddenly becoming stiff. So I've used this term seizures tickle the brain, and here's just another slide to sort of demonstrate that in further detail. So each region of the cortex, that's the outer covering of the brain, is responsible for processing a sensation or producing some type of behavior. And if a seizure is involved in that area, then you may get activation. So if a seizure is involved here in the somatosensory cortex near the tongue region, then you might get a sensation. Maybe the first sensation of a seizure is in the tongue. If a seizure starts, let's say, around the face in the somatomotor cortex, you might get muscle tightening on that side of the body. So it might cause pulling or jerking of that side of the face. And we have all kinds of examples. The textbooks have pages and pages of these types of signs that we can observe that correspond to specific regions of the brain that can help us understand where the seizures might start. So, for example, if somebody has bipedal automatisms, which is sort of like a bicycling motion of the feet, we can surmise that it's probably coming from the frontal part of the brain. If they have sudden unexplained laughter at the beginning of their seizure, then we can be fairly certain that it's starting in the hypothalamus, or maybe less likely the temporal lobe. So we admit patients into the hospital to observe their seizures, and we do that for various reasons. Sometimes we need to make sure that what people are experiencing is actually a seizure. Sometimes we want to know whether somebody's seizures are generalized or focal, and that's for a couple of reasons. Most importantly, because we might choose a different medication, whether it's generalized versus focal. Sometimes people are having a lot of seizures, and we need to get medications on board quickly, and we need to get their seizures under control. So we admit them to the hospital for that purpose. Sometimes they have unexplained increase in seizure frequency, and we're trying to figure out why. But the most important reason, the most common reason rather, that we admit people to the epilepsy monitoring unit is if we think that surgery might be the best option to control their seizures. So we call that a pre-surgical workup. And the jargon terms we use are phase 1 and phase 2. Phase 1 is when we're recording patients only on the scalp. So there's no surgery involved. We're just monitoring their seizures with the EEG test, recording on the level of the scalp. A phase 2 study is when we have to do a surgery to implant some electrodes in the brain to record seizures at the level of the brain tissue. So I alluded to the second video. So this young gentleman who's also documenting his experience with epilepsy that's been refractory to medications posted this video on YouTube of one of his seizures in the epilepsy monitoring unit, not here at Cottage, but elsewhere. And what I just want you to observe that we talked about some signs that indicate that someone might be having a seizure, and I want you to observe his behavior and see if you can pick some of those things up. Okay, so this seizure actually is fairly prolonged, and I'm just gonna fast forward a little bit and show you closer to the end of the seizure. So look at his face closely. They apply an oxygen mask and are using suction to remove some of the saliva to keep him safe. And the seizure is over now, and now he's in recovery. So there were, some interesting features to that seizure that would help us localize where in the brain that seizure is coming from. You probably saw him chewing and licking his lips and moving his right hand non-purposefully. And then at the end, you saw the jerking on the right side of the face. And also, we use probably our most important tool other than our eyes is the electroencephalogram, or EEG for short. This is the brainwave test. And what this test shows us, is it shows us where the abnormal excessive electrical activity is coming from. And although I don't expect you to be an expert in reading EEG, I'll tell you right here, this is the excessive abnormal electrical activity and is occurring right here in the front and temporal regions of the brain. So this appears to be a frontotemporal seizure or an anterior temporal seizure. And we also correlate what we see both behaviorally on the EEG with imaging tests. In this case, we have an MRI scan, not of this patient, of course, but I just pulled up an MRI scan that shows what we might expect to find. And that is, if you can see my mouse, we see some brightness and some loss of volume here in the right temporal lobe. So it appears that this patient has mesial temporal sclerosis, or MTS. And if that's the case, then with all the findings, the behavior during a seizure, the electroencephalogram showing it's coming from the right side in the temporal region, and the MRI finding. With those concordant findings, we can often proceed safely with surgery with a few other tests. And the success of those surgeries is often very high. So epilepsy type matters. So I mentioned that we monitor people in the epilepsy monitoring unit because we want to figure out what type of epilepsy we have. And here are some examples of why that's important. So some types of epilepsy respond to certain medications. So in the case of absence epilepsy, ethosuximide is a phenomenal drug and works very well, better than most other drugs, and is very well tolerated. And sometimes there are types of epilepsy that can get worse on certain medications. So in the case of myoclonic seizures, lamotrigine might make it worse. So we don't want to make anybody worse by adding a medication. Sometimes we know that certain types of epilepsy respond very well to surgery. So mesial temporal lobe epilepsy, 80+% chance of rendering somebody seizure free with a temporal lobectomy. That's a removal of a portion of the temporal lobe. Some types of epilepsy are expected to spontaneously resolve and aren't treated with medication at all. This is a pediatric epilepsy diagnosis, but benign Rolandic epilepsy with centrotemporal spikes is often not even treated with a medication, even though the seizures are fairly troubling, and they are self-limited, and the kids grow out of them. And some types of seizures are triggered by certain stimuli. Probably the most common example of that is photosensitive epilepsy. And if we can advise patients on things they can do to prevent a triggered seizure, then we love that information. So another reason to bring patients, I alluded to this, another reason to bring patients into the epilepsy monitoring unit is sometimes we find that people don't have epileptic seizures at all. They have something else. So syncope is a disorder where there's reduced blood flow to the brain, and it sometimes can appear like a seizure. There are movement disorders like dystonia or hemibolismus, which can look like epilepsy. Migraine can produce symptoms on one side of the body, and produce things like speech arrest that can look like a seizure. Tic disorder are rapid movements of the body that sometimes look like epileptic myoclonus, but are not. And not all myoclonus is epileptic. Sometimes the myoclonus is related to drugs or other phenomenon in the central nervous system, but is not related to epilepsy. Panic attacks, these sudden episodes of fear, diaphoresis, tachycardia, they can sometimes look like seizures as well. And then probably the most important and common other category of things that look like a seizure, like an epileptic seizure, but are not, is a condition called psychogenic non-epileptic events, or sometimes called psychogenic non-epileptic seizures. And these are events that are behavioral, physical manifestations of underlying psychological distress. So unresolved emotional trauma can manifest physically and render a person unable to respond, can cause stiffening and shaking that looks much like a seizure. But the difference is, in this case, that the brainwave activity during these events is normal. So there is no abnormal excessive brain activity. And psychogenic non-epileptic events are not treated with an anti-epileptic drug. They're treated with something called cognitive behavioral therapy. So there won't be a test on this, I promise. I just wanted to display the drug development over the last century and a half. So we're here at this. So this is the year, and this is the drug, and this is the number of drugs. So we're upwards of 45 drugs here, and we're right here from 1990 to present day. There's been an explosion in drug development, and that's a great thing. But you might question, why do we have so many drugs? Do we need all these drugs? And the answer is yes, because we have not found a drug yet that works for everybody's epilepsy. So although in general the drugs have similar probabilities of rendering somebody seizure free, some drugs just work better on some people, and some drugs work better on others. And also the side effect profiles differ significantly as well. So one person might tolerate a medication very well, and another person may not tolerate that medication at all. So it's good that we have these choices. It makes our job a little complex because we have to decide what to use and then move to other drugs if they're not working. But there will continue to be drug development like this until or if we find a silver bullet. We have broad spectrum drugs and narrow spectrum drugs. That's the only thing I want to mention about this is that these broad spectrum drugs on the left-hand side are nice because we don't do an epilepsy monitoring unit study on all patients, and it's nice that we have drugs that are broad spectrum that we can be fairly certain are good for all types of seizures. And so this is our list of drugs that we might use on somebody that we're not quite sure, but we know they need to be on a seizure medication. These, on the other hand, on the right-hand side, are narrow spectrum, meaning that they will not work on all types of seizures and may actually worsen some types of seizures. So we feel better using these after we've established a more clear diagnosis. So how do medications work in general? How well do they work? Well, I'd say pretty well, but I wish it were better. So this is a study that looked at patients who were previously not on any medications, who have a new diagnosis of epilepsy, and they were given a medication and followed over time to see if they remained seizure-free. And after the first medication, 47% of people remain seizure-free. That seems to me like a huge win. So we started off knocking it out of the park. Now, if that patient or that person fails to respond to that first medication, they continue to have seizures despite increasing the dose, there is only about a 13% chance that increasing or that adding another drug will render them seizure free. And then if they continue to have seizures and we add a third drug, we only get another 4%. So in the best case scenario, we're dealing with on a population level with a sizable number of people. So more than a third of the people are not responding to medication. And I wish that were better, and hopefully drug development continues. So what do we do when medications just aren't cutting it? Well, I'm going to talk about two new pieces of technology that I think are great options. The first is called a vagus nerve stimulator, or vagus nerve stimulation. It's an implanted device. So that's placed, the actual battery and the computer is placed under the skin and the side of the chest wall, and you can't see it. And it has a wire that wraps around the vagus nerve, and it produces electrical impulses that travel to the vagus nerve, and it uses the vagus nerve as a back door into the brain, where those electrical impulses are dispersed to wide areas of the brain to change how brain cells function. And in that way, it reduces the seizure probability. So the usual statistic that we give patients is that 50% of patients experience at least a 50% reduction in seizures. So sometimes much better than that, maybe 90% or even 100%, but 50%. So about a coin flip that you're going to have at least half as many seizures as you were having before. And there really aren't any side effects to this treatment. So people like it because sometimes we can use this device to avoid adding a third drug, for example. So another technology that we've recently adopted at Cottage is something called the laser and interstitial thermal therapy, or LIT. And when a patient has an area of brain tissue that we know is the source of their seizures, so they have focal epilepsy and there's an abnormal cluster of neurons, and we've identified that through our testing, we have an option of removing that tissue, so with a knife, or using a laser, which is minimally invasive, and using heat to destroy that core area of abnormal cells. And when we destroy that abnormal core of cells, then there is no longer a propensity to develop seizures. So this is a great option if someone has a known localized area and wants to avoid a larger surgery that requires removal of a piece of bone. And finally, we have something called the responsive neurostimulation, or RNS. So this is also a device. It has a computer and a battery. It's quite sophisticated. It has to be programmed. It is placed under the scalp, flush with the bone. As you can see here, they create a little tray and they put the battery and the computer right here on the bone. And then it has leads, up to 2 active recording and stimulating leads that can go to really any place you choose in the brain. And what it does is it records seizures in real time. So as soon as it detects that there is a seizure occurring, it delivers an electrical impulse to break up that abnormal electrical activity. So if you think of the excessive abnormal electrical activity as like a wave of electrical activity, if you disrupt that wave, then will lose its momentum. And hopefully in that way, you can prevent the seizure from becoming a larger seizure. Now, this device is a great option for people who have either an area that cannot be, an area of brain tissue that's producing seizures that cannot be removed, or if their seizures come from more than one area of the brain. We have a number of patients now at Cottage Hospital who've received this treatment, and we're really happy with the successes we've had. So thank you for listening, and I think we're going to open it up now to questions.
Thank you so much, Dr. Gibbs, for that insightful presentation. We're going to move now into the Q&A session. We have a few questions, so we'll do our best to get through as many of them as possible. For our attendees, if you haven't submitted your questions, please type them in the Q&A box at the bottom of your screen, and I'll read them to Dr. Gibbs. So let's start with our first question. Our first question was, when you touched on spontaneous seizure, does that mean they are unprovoked?
Yeah, I think that that's synonymous. So a spontaneous seizure is a seizure that's not provoked, for example, by a medication. There are some drugs that we know can cause somebody who wouldn't have a spontaneous seizure to have a seizure. The antidepressant Wellbutrin is probably the most common that I see prescribed that causes seizures. And all we have to do is stop the medication and the person will not have any more seizures. But also there are legal and illicit substances that can produce seizures, alcohol being the most common. So there are a number of people who have seizures that are entirely related to alcohol consumption.
Wow. Thanks for that clarification. When is a syncope similar to a stroke? We actually have two questions that same realm. So, or what's the difference between syncope and a stroke?
Oh, great question. Yeah. So syncope is a transient low blood flow state. So there isn't a blockage of flow, but the flow, the perfusion, or the pressure that's going into the arterial system of the brain isn't enough to maintain consciousness. So somebody passes out. And one of the consequences of passing out is often you fall to the ground and your body is flat. And just that extra help from gravity of pulling blood into the brain often results in people regaining consciousness.
Okay, perfect. Thank you. Is there a particular type of seizure that occurs during sleep? And is there a particularly good treatment for those types of seizures?
Great question. So some people will have only seizures during sleep. We call it nocturnal epilepsy. Some people have seizures both in sleep and during wakefulness, but there are a group of patients who just have seizures during sleep. And it doesn't necessarily predict the type of epilepsy that you have. It could be, for example, frontal lobe epilepsy or temporal lobe epilepsy. Probably frontal lobe epilepsy is the most common type to happen only out of sleep, but I do have a number of patients who have only nocturnal seizures and they have temporal lobe epilepsy. But in general, whether it occurs during sleep or wakefulness does not dictate which medication we use. Sometimes, this doesn't come up that often, but sometimes we might actually give a larger dose of medication at bedtime if somebody only has nocturnal seizures to cover them better during those hours.
Thank you for that. That's a great explanation. We learn something new every day. How can we help someone who's having a seizure?
Yeah.
Active seizure.
These are all fantastic questions. We could talk about epilepsy for hours. So if you observe having somebody having a seizure, the good news is there's not much you really have to do, but there are a few things. So you're mostly off the hook. You don't have to do CPR. So the first thing you want to do is, if you can, assist them to the ground so they don't have a fall. If they've fallen already and they're on the ground, then try to keep their head from hitting nearby objects or the ground. Basically, you're preventing kind of superficial injuries at that point. And you're going to want to roll them onto their side. It's pretty uncommon for people to have emesis or vomiting during a seizure, but it's not that uncommon to have vomiting after a seizure. So if they're on their side, and they end up vomiting, then that can not go back down their breathing pipe. Similar with secretion. So most people who have a generalized tonic-clonic seizure will have a lot of saliva in their mouth. Now, you saw the fancy suckers the nurses had. We don't have that, but we can put them on their side, and most of the saliva will fall out of the mouth and rather than going down the windpipe. And then the last thing you want to do is get a sense of how long the seizure is lasting. You might check your watch, but that, I'd say most people don't in that moment. But if the seizure is prolonged, if it's lasting, 3-4 minutes, and it's not resolving. So the actual motor activity, whether it's jerking or stiffening, is not resolving by the 3 or 4 minute mark, and they're turning blue because you don't breathe during a seizure, then it's a good idea to go ahead and call an ambulance or get help. But most 99.9% of seizures resolve spontaneously within a couple of minutes. And if this person is known to have epilepsy, and they didn't suffer any injuries, then the vast majority of those people do not need to be rushed to the ER, because the ER generally it doesn't have really much to offer patients with epilepsy and uncontrolled seizures.
Great, thank you for that. Have you used a ketogenic or low carbohydrate diet to treat epilepsy? What are your thoughts?
Yes, so great question. So I did my residency at Rush University, which is a level 4 epilepsy center, and they had a ketogenic diet clinic that I rotated through, and it was fantastic. People loved the results of the ketogenic diet. So for a normal adult, normal functioning adult with normal intellect and access to food, generally what we're talking about is a modified Atkins diet, which is a diet which promotes ketosis, but not a true restrictive ketogenic diet. But either way, I mean, that's just semantics. But these diets do work, and the caveat is that you really have to do this under the guidance of a nutritionist, of a dietitian rather, who has experience doing this, because it is a pretty specialized area of a dietitian's training. And I have yet to identify somebody in our community on that end who can assist our patients doing the ketogenic diet. But I certainly am not I'm not done looking for that resource.
Great, thank you. With absence seizures, there isn't much definitive information on its impact on behavior. So where can one get more information on childhood absence epilepsy and its impact on child development?
Yeah, and that great question. That's a complex question, and probably the best person to answer that would be a pediatric epileptologist. So hopefully you've established with a pediatric epileptologist, but if they're not providing, answers about that question, then you might reach out. Well, you might get a consultation at like an academic center. My understanding as an adult epileptologist, and I have a few patients with refractory absence epilepsy, is that the effect on development is pretty minimal. But I don't have all those statistics at my fingertips.
Great, thank you. This one's more situational. If a head injury has occurred, is that an example of a type of cause of seizure that is easily located and can be remedied by implants and/or surgery?
Yeah, we call this post-traumatic epilepsy. So if the cause of somebody's epilepsy is head trauma, then yes, we've had some success treating that type of epilepsy with surgery. It is relatively speaking, it can be a more complex type of surgery to treat with surgery, because often the injuries are in more than one spot. When the brain sloshes against the side of the cranium, not just one area of the brain gets affected, it's usually several sort of hot spots. And so sometimes those patients are better candidates for a device like an RNS or a VNS, but there have been great success stories in resection or removing a piece of brain tissue in post-traumatic epilepsy.
Great, thank you. This is a unique question. How much is known about museogenic epilepsy? I may not have pronounced that correctly.
Musicogenic epilepsy?
Yes.
I don't think there's a lot. It's a fairly uncommon form of what we call reflex epilepsy. Reflex epilepsy is a type of seizure or type of epilepsy where seizures occur in response to some kind of external stimulus, like music, for example. So it's relatively uncommon. So I'd say most of the information that's available about that is just like case reports, like people publishing about their patient with this type of epilepsy, and how they perhaps how they treated them successfully, or what medication they used, or what surgery they did. But because it's rare, it's really limited to case reports like that.
Great, thanks. Could you discuss the correlation between epilepsy and glucose? So GLUT1, so it's glucose transporter 1 deficiency?
Oh, yeah. So I'm curious. That's a relatively rare also form of epilepsy. It's I actually don't have any patients with that disease, so I don't know much about it. But it is caused by abnormal transport of glucose in certain areas of the brain, and can cause epilepsy and other symptoms. But other than that, I don't have a lot of information.
Okay. Well, we have time for one more question. So let me see. We have a few more, but we're going to wrap it up. How do patients handle social results of epilepsy, such as not being able to drive or meet new people or have to move home if they're a young adult?
Yeah, and I think that's probably one of the hardest parts, certainly for me to watch, is when people's lives get smaller, more restricted, less independence, less freedom. And it's probably, certainly in people like, I have a number of adults who, flew through, all of their education, and, maybe are in the early periods of their career, or maybe they're in college still, and they develop seizures, and we're having difficulty getting control of them with medication. You can imagine, you watch that seizure of the young gentleman at the beginning, these seizures are observed, by everybody around them, and are quite disruptive. And patients, rightly so, feel unsafe sometimes in their environments. They may be away from family. So it's a huge negative consequence of having epilepsy, and one of the reasons why we work so hard to get people seizure free, because if we can get people seizure free, that that produces huge benefits in terms of people's development, their economic success, their emotional well-being, that aren't really quantifiable in any other way. So seizure freedom is our goal, our holy grail in epilepsy. Sometimes it's just medication, but sometimes we have to go to surgery, and sometimes even surgeries don't get us seizure free. So it is, I'd say, the original question was, how do people respond socially? If we've tried everything and they still have seizures, then it's probably, one of the hardest aspects to deal with regarding the disease is the impact on people's social and economic well-being.
Thank you so much for that. So it looks like we're out of time for questions today. I want to thank everyone for your questions and for joining us this evening. Big thank you to Dr. Gibbs for sharing your expertise with us. Dr. Gibbs serves at the Cottage Epilepsy Center located in Santa Barbara Cottage Hospital at 400 West Pueblo Street. For more information, please call 805-832-3633 or visit cottagehealth.org/epilepsy. We will also send an email with a recording of this presentation later this week. And lastly, before you go, a brief survey will appear after this webinar closes, and we'd love to hear your thoughts. So thank you again for joining, and have a happy and healthy rest of your evening.